So the myelodysplastic syndromes are a group of diseases, actually. Although MDS is uniformly a disease of the ineffective production of red blood cells, white blood cells, and platelets, there really are many causes of myelodysplastic syndromes. And in fact, the way that myelodysplastic syndromes behave is highly varied. Some myelodysplastic syndromes are benign, requiring no treatment. Others are life-threatening and require intense chemotherapy. Because of this, a highly tailored, personalized approach is required for the treatment of MDS. So before you start treatment, there really are two key questions that you and your physician need to address. The first question is, do I have symptoms due to my MDS? And what I mean by that is, are the blood count issues, are the cytopenias causing symptoms? The second key question is my MDS going to behave benignly, or is my MDS going to behave aggressively? So you may be asking, how do I know how my MDS will behave? Well, there's been an enormous amount of research looking at prognostic models that help your physician decide whether your disease will behave benignly or aggressively. But in general, all of these risk groups can be distilled into two categories, lower and higher risk. And they're really distilled by looking at three key parameters. Those are the chromosomal pattern of your MDS, the percentage of myeloblast cells in your bone marrow, and your blood counts. So after these questions are answered, the next step in deciding treatment is to ask the question, do I need treatment at all? And we ask that because many patients with myelodysplastic syndrome do not need treatment. Patients with lower risk disease who have no symptoms due to their disease do not require treatment, and in fact can be watched until the time that their blood counts decrease such that symptoms arise. However, if you have lower risk disease with symptoms or higher risk disease, treatment is indicated. So what kind of treatment are we talking about? Well, in lower risk symptomatic disease, we are talking about treatments that directly address the symptoms. For instance, if you have anemia, the treatments should be designed to improve the anemia. There are a series of treatments that can do this. The usual algorithm starts with erythropoietin, a naturally occurring protein made by your kidneys that stimulates your bone marrow to make blood cells. Other lines of therapy that can be used are lenalidomide, an FDA-approved medication for the treatment of myelodysplastic syndrome. This medication is given orally and is especially effective in patients who have a loss of chromosome 5. A second medication shown to improve blood counts is 5-azacitidine, or Vidaza. This is also an outpatient medication. It is given either as a subcutaneous injection, like an insulin shot, or as a 30-minute IV infusion. This medication can be given over 5 days in a 28-day cycle. The approximate chance that your anemia would improve with Vidaza is 40%. The side effects of Vidaza include constipation and injection site irritation, which can all be controlled with fairly straightforward supportive measures. Other medications that can impact your anemia include decitabine, a cousin of Vidaza, given IV. The side effects and the course are very similar. If your disease goal is to improve the natural history of your MDS, if your disease is high risk, then the goal of therapy is to prevent your disease from transforming to acute leukemia, making you feel better, and of course, making you live as long as possible. In this case, the FDA-approved medication that has been proven to make patients with myelodysplastic syndrome live longer compared to other courses of therapy is 5-azacitidine, or Vidaza. In this case, it is usually given over a 7-day period in a 28-day cycle. The side effect profile and the other issues are similar to that in lower risk. Decitabine can be also given on a 5-day schedule. However, this drug has not been proven to improve overall survival, but has been shown to have similar response rates to Vidaza. The third medication, lenalidomide, has also been tried in higher risk disease. In this case, it improves symptoms and increases the response rate to about 30%. So many patients ask, can my myelodysplastic syndrome be cured? Well, the answer is yes and no. If you are a candidate for a bone marrow transplant in which an immune system from another patient, from another donor, is transferred into your body, then the answer may be yes. Unfortunately, many patients with myelodysplastic syndrome are not candidates for a bone marrow transplant. A bone marrow transplant carries a significant risk, and therefore it involves a detailed discussion with you, your physician, and the bone marrow transplant team. If you are not a candidate for a bone marrow transplant and you have tried therapy like Vidaza, lenalidomide, or decitabine, an important arm of your treatment should involve clinical trials. So the last 5 years have really exponentially increased the amount of information that we know about myelodysplastic syndrome. And this is increasingly translating into clinical trials for potential therapies that may improve your myelodysplastic syndrome and lead to long durable remissions. We recommend clinical trials for any MDS patient, especially if they're not candidates for transplant. Let's talk about bone marrow transplant. Bone marrow transplant is an effective therapy for myelodysplastic syndrome in selected patients. It is the only therapy that can result in long durable remission and cure in highly selected individuals. However, significant risks are associated with bone marrow transplant, and therefore a careful conversation between you, your physician, and the bone marrow transplant team should be undertaken to determine if you are a candidate for bone marrow transplant. In conclusion, I'd like to thank you for listening to our video and wish you the best in the treatment of your myelodysplastic syndrome.